Hi, my name is Nooka. I'm a professor in the Department of Hematology and Oncology, and I'm the director of the Myeloma program at Emory. At ASCO 2023, the phase 3 results of DSMM study were presented. So this is DSMM 17 study that evaluated KRD, which is carfilzomib lenalidomide dexamethasone, versus the addition of elotuzumab to KRD among younger patients who are transplant eligible with newly diagnosed myeloma. So why was the study done? The addition of daratumumab to the triplet agents, the VTD, VRD, KRD, has been shown to be beneficial among the patients with newly diagnosed multiple myeloma in deepening the responses and increasing the progression-free survival. Similar results were seen in combinations with the other CD38 monoclonal antibody, which is isatuximab. In this context, elotuzumab, which is a CS1/SLAMF7 monoclonal antibody, was evaluated in combination with VRD or without elotuzumab, done by the same group, the DSMM group, showing no benefit of addition of elotuzumab. This study, the DSMM 17 study, evaluated KRD versus KRD plus elotuzumab for two primary endpoints. One is MRD negativity at threshold of 10 to the power of -5 by NGF, which is next generation flow. And the second co-primary endpoint is the 3-year PFS rate. The study design included 576 patients randomized to ELO KRD or KRD. Those patients who received the ELO KRD arm or the KRD arm received 3 cycles altogether first, and patients would undergo Cytoxan mobilization and would receive 3 further cycles of ELO KRD. And the first co-primary endpoint is the MRD negativity at 10 to the power of -5 after these 6 cycles of ELO KRD. Then patients would undergo a stem cell transplant, would receive 4 further cycles of consolidation, and the ELO arm would receive ELO-len, and the KRD arm would receive lenalidomide as maintenance. Here, the carfilzomib dosing was 36 milligram per meter square, given on days 1, 2, 8, 9, 15, 16, every 28 days. So if you look at the primary endpoint, again, this is the first co-primary endpoint that was presented at ASCO of 2023. The VGPR rates among and the MRD negativity rate at 10 to the power of -5 were close to 50% versus 35% for the patients who received KRD. So the addition of elotuzumab has resulted in an MRD negativity rate that was higher than without addition of KRD. So if you look at the safety, the ELO KRD versus the KRD arms, the safety both from the hematological profiles, the non-hematological safety adverse event profiles, as well as a metabolic adverse event profile, all of those were picture perfect, exactly reflecting that addition of elotuzumab did not impart higher toxicity. This is not new for us. We had seen it in the relapse setting. Addition of elotuzumab to lenalidomide dexamethasone, addition of elotuzumab to pomalidomide dexamethasone is very well safe and very well tolerated. So now, what do these results show us or teach us? Number one, this is the first positive study of elotuzumab addition in the induction setting, supporting quadruplets could be used in the induction setting in younger patients. Is the study practice changing? The answer is no, because we have much more safety data, efficacy data, PFS data that was supporting the usage of CD38 monoclonal antibodies in the upfront setting. So we don't even have the second co-primary endpoint, the 3-year PFS rate, to support the addition of elotuzumab in younger patients. So this is a good study. Safety is impeccable, as well as the efficacy is good, but we will have to wait for the other co-primary endpoint of 3-year PFS rate down the line.